Thank you so much. I thank ORF for asking me to be here on such an important subject. And really thank you to all for staying, coming back from lunch in time. We're going to make this a conversation and then open it up so that we really keep you engaged in all that we discuss. I think since morning we've heard some brilliant speakers, and they've kind of set the stage for this panel. So we know that we've got the largest cohort of adolescents today than ever before. We know they have needs, and while we recognize that there are challenges and we are not addressing their needs to the fullest, we also know that if we want a significant development in India, we need to address their physiological, reproductive, mental, emotional needs. And it's critical that we invest in them today, because then we can look at intergenerational shifts and we can look at realizing the demographic dividend. Although, as I told my panels, I don't like to use that word. I think we need to make sure they're educated. We need to make sure they're equipped with information. I think an important thing that we also realized in the morning discussion was that we're dealing with a heterogeneous group. This is not just one group where we can design programs and it'll work across. It depends on the level of education, their age, where they are based, so many other factors. But I think today we have a really, really experienced panel, and from different sectors, different groups. For example, we do have donors, and then we have very strong implementing partners that are also at the forefront of rights conversations where adolescents are concerned. What I'm going to do is, in the interest of really starting out, for each one of you to just introduce yourself and speak very briefly about your passion when you really speak about adolescence. So Aparajita, I'll start with you.
I work for an organization called Center for Catalyzing Change. We've been working in India since 1987, primarily on ensuring that adolescent girls and women meet their full potential. Initially, we started off as typical smaller NGO programs, but today I'm privileged to say that we are implementing programs at scale which respond to the needs of young boys and girls.
Hi, I'm Medha, and I work at the Bill and Melinda Gates Foundation. And in terms of the portfolio assigned to me, I look at family planning and MNCH from a policy advocacy lens. But truly, in my heart, I come from a very strong rights agenda and looking at an individual in their right and how we can get the best kind of services across to them. And I constantly struggle each day to try and get the individual at the center in all the work that we do. It's a large organization for us, research for what will happen 5 years, 10 years, 20 years, 40 years from now, and how do we create opportunities for the current research to be implemented across. And within that, I'm constantly struggling. So I see this as a very strong opportunity to hear the kind of voices that need to be heard. And I think I'm extremely privileged to be sitting with experts who know it all, who've done it all, who've been the voice for the longest time. So I'm really glad to be here.
Thank you. It's very heartening to see more and more adolescent meetings happening, honestly. Personally, it gives a lot of satisfaction to see. One started working in adolescence somewhere in mid-90s when the word of adolescent was still emerging. Being a pediatrician, we always felt it was the third spurt in life. It was totally not taken into account. So getting from adolescent programming to seeing that the 10th plan, 11th plan, 12th plan brought this issue of adolescent very firmly into the planning process, and then supporting and strengthening the state's response was a journey that me and the institution went through. But the learning that also came a lot was from the global learning that we had, being part of the WHO, being part of the regional meetings to understand. Why I'm saying this, it's important for all of us to learn what we learned at one time and then transmit it back to the local context. But adolescent programming is what we focus a lot System strengthening is what we focus a lot, but adolescence still needs a lot of advocacy, a lot of state level advocacies are needed. And I think we still not there. We are still in Delhi and capital, and the converts usually come to the meeting. We need to get to the non-converts and get them understand why adolescent needs to be done, why per se it's their right, and not just their right when met will be the right of the humanity. If we are looking at SDG 135, you cannot achieve them without adolescent health being at the center stage. You cannot achieve many of your gender equality issues if you don't invest in adolescent and in early adolescence. So I think I'm very passionate about it. I think it's something which I feel we all need to get gradually passionate and engage more and more partners who could be with us as we move further. Thank you.
Good afternoon. I am with the World Bank. I've been with the World Bank since roughly 2005, and I've been working mostly on Africa and on South Asia. And for the last 2 years, I've had the privilege of being based in Delhi. Throughout the time that I've had at the World Bank, we focus mostly on system strengthening, but with the goal of poverty alleviation. So our entry point is a little bit different, but often what ends up happening is quite similar. It's been very encouraging and exciting for me. While I was working in Africa, there was a big movement to push on the adolescent girls' agenda specifically, not only on health, but also through skills and through education. And it's exciting that now that I'm in Delhi, I'm seeing a lot of the same things here. So I'm really excited to be here, and I'm really excited to participate, and especially after this session, no offense, I'm really excited to actually hear about the state-level initiatives that have been successful, because from the side of the World Bank in India, we really do think the future of India lies in the states, and that's really where implementation is happening. That's where rubber hits the road. So very excited that this event is happening, and excited for the different panels, because I think that they bring different pieces to the table.
Thank you, Rifat. And the way I'm going to start is I'm going to speak to you and Medha first, and then really speak to Dr. Mehra and Aparajita. So I think my first question to the two of you is that both of you are partners to the government, both at the national level and at the state level. And I just want to know, how do you make your decisions on the various programs that you work with the government, and where do adolescents really fit in that? So if you can speak a little bit about that. And obviously for you, your priorities would be more programmatic, your priorities would be financing as well. So where do you see that linkage?
That's a tough one. So how do our priorities get decided? So it's a two-way process. One is, as I said, that we're a very data-driven organization. So for us, what current data tells and what data trends show define to a large extent what are the things that we're going to prioritize. And sometimes what does happen is that data becomes more important than people itself, which I guess tends to happen in a large organization, and I'm not being overtly critical of our own selves, but being cognizant that that does happen, and numbers tend to tell a bigger story than what people probably do. So that does define the areas that we need to move in, and for us, strong declines, elimination, these are huge priorities. So how do we move in those directions, and how do different pieces sort of fit in? So from that point of view, that's a larger set of how our strategic directions are decided. At the country level, it is in partnership with the government. So we do come with certain areas which we are definite to be working on. Then there are others on which we are flexible. And there are certain areas where we don't work, because otherwise then there's just no limit. How that negotiation happens is where the government really wants us to support, and where we have a technological edge. We are a very technology-driven organization. So we bring all of those things also in. But a lot of our focus internally is to try and get voices. So it gives me great pride to say that both the people sitting to the left and right, or let me say, I'm sitting between two experts who are great partners with us, and it is really their voice that we get to amplify. At the national level, at the international and global level. So that gives us that opportunity. Now to the more difficult question. Adolescent health per se doesn't stand as a pillar for us, but it sits across various thematic areas, not just in health. I mean, when we look at our financial services work, there also we look at how young people can have more access. How do we leverage the power that lies within? We do a lot of work in digital, so how do we make sure that we're really understanding trends that young people, how are they using technology, how can that be taken forward? Within the health space, having smaller chunks of programming that is designed to them, which is across nutrition, health, so it's that way.
Okay, so I think the entry point for the World Bank is we have two goals. So we have two institutional goals. One is to eliminate extreme poverty, and two is to boost shared prosperity. So any type of priorities that the bank will focus on for any country has to fit into one of those, and we internally have to make the case that whatever we're investing in will get us to one or both of those ultimate goals. So that's our entry point. So I'm in the health sector, but we also have a broader human development family, which includes health, nutrition, population, education, and social protection. So often we end up making the arguments more jointly, not only for health, but across human development, to make the case for how these investments will impact poverty alleviation and sharing prosperity, so it's more inclusive growth. So if that's the case, then whenever we also, I think just like the government has its own tug of war on allocations of financing between different ministries, the World Bank has the same thing. So we have different global practices. As I said, health is one, education is one, social protection is one, which are I think the ones that we often in this room are much more familiar with. But we also have infrastructure, energy, roads, transport, and just like in government, also in the World Bank, those are the sectors that often end up getting the bigger chunk of the financing. So even internally, we have to play some of the same game and make some of the same rationale and cases for investing in the social sectors. Now, our main entry point is really human development and human capital accumulation. And this is where I think the adolescent agenda and adolescent girls agenda in particular has really gained some traction internally. There was a World Development Report that the World Bank had produced a while back, actually in 2007, on youth and the next generation, and how do we actually empower adolescents and youth to not only help themselves, but also help their countries economically. And I think there was some discussion about this morning in terms of health, in terms of nutrition, in terms of skills, in terms of female labor force participation, and all of these really do contribute to economic growth and shared prosperity. So that WDR report, the World Development Report in 2007, really highlighted and elevated the importance of adolescents as a group and youth as a group for us to really invest in and to nurture and make sure that they can be citizens of each society and be productive members of communities. The other thing that it really did is establish that beyond early childhood, so beyond the early years and below, so from gestation until 5 years of age, adolescence is the second most sensitive period for human development. And this is really important because it's not only for health and that, but it's really human development and contributions to society and economic growth. And for us, working on adolescent agenda, or even people who are working on health specifically or education specifically, this gives us a platform to really say, look, it really does contribute to the economic development. And I think this is where we're having a bit of a discussion over lunch today about how the terminology on demographic dividend is a bit controversial because it kind of dilutes many of the things that are within it, right? But it also does provide an opportunity. And I think depending on the organization that you're in and the counterparts that you have, it can be one of the tools that can be used to really get this on the agenda, both the financing agenda as well as the implementation agenda, because it really provides a very strong platform for human capital and for human development, which includes health, education, social protection, but specifically on the adolescent age period, given how sensitive it is and how impactful it can be. So I think one thing we need to be a bit careful about, and we talk about this internally quite a bit as well, is that when we talk about decisions made during adolescence, I think we need to really be cognizant of who's making those decisions, right? Are adolescents themselves making those decisions? How many of the decisions are they making versus others? And so when internally, when we're thinking of how to do our programming and where do we invest, we're trying to think about that whole spectrum. Finally, for the World Bank, our client is the government. So we often, or always, are really following the government lead in terms of what its priorities are, both in terms of financing as well as in terms of technical assistance. So part of it is for us to do our own internal work to advocate and to mobilize financing. Part of it is to actually work with governments and different parts of the government to advocate for the same. Because if it's not a government priority, it'll be very difficult for the World Bank to then follow the government's lead, because we work within a strategic country diagnostic framework, which is an agreement between the World Bank and the government on what the strategic priorities jointly are.
Yes. Thank you. And I know the World Bank has done tremendous amount of work in even trying to shift the government's approach on involving the private sector, and I know that's been a real success. So moving on to you, Dr. Mehra and Aparajita, I think you are at the forefront. You're really the ones, both of you, implementing the programs. What has been a key focus of your approach? And in that, we are talking about adolescents, but even in the adolescent world, it's a huge range of approaches and interventions that you can make. So what has been your approach, and what are the early things that you're hearing from the ground? And that's to you and Dr. Medha.
Thank you, Anjali. We've been working with young people for over 30 years, and often when we interact with them, what they tell us is that you are looking at us from your point of view. The policies, programs are very instrumentalist. You are looking at a young girl, you're treating her like a mother in waiting, not an independent, productive being in itself. Pick up any curriculum. Many of us are teaching 15-year-old adolescent girls the benefits of exclusive breastfeeding. I mean, think about it, right? So what we are trying to do in a very, very small way is try and look at programs which also respond to the aspiration and needs of the young people. Look at boys, work with boys not just to prevent them from being violent and become lumpens and create troubles, but look at them from their points of view of what they need. Often when we work with girls, boys come and tell us, why are you not working with us? What makes you think that we have that agency which you're trying to create with adolescent girls? So my two kind of points, one is work with both boys and girls, and we often forget boys. Absolutely. And the second one is really try and understand and respond to their needs and their aspirations. In this kind of line of thought, about 7 months back, we initiated kind of a survey called Youth Bowl. There are copies around if you all want, but the idea behind this was to reach out to young people across the country, give them a kind of a postcard and ask them what do they want. So, आपके लिए स्वास्थ्य में क्या बहुत ज़्यादा ज़रूरी है आप वो लिख के दीजिए. We reached out to 110, 1,10,000 young people across the country, including from the age group of the younger adolescent age group, about whom we don't really have much data. When we finally got the data from 27 states, 4 union territories, and we looked at the data, initially we thought, as usual, that we know what's going to come, and we had created codes. कि हम ऐसे coding करेंगे, but when we saw what young people have sent in, we had to go back to the drawing board and recode. The first thing that happened was that young people look at health much more holistically than we do. For them, health meant playgrounds in the school. For them, health meant, midday meals must be provided till class 12, not just for nutrition, because if there is food in the school, parents will send the girls to the school. So we looked at all of this, and of course, 36% of them did ask for health information, health services. When we kind of disaggregated the data, we found out that they are looking for schools to deliver specifically SRH information. many items came up, and I'm going to talk about two which young people really, really wrote about. One was why is there not enough conversation about managing menstruation, managing menstrual pain? So what we know as program implementers is distributing sanitary pads is just the tip of the iceberg. They need a lot more.
Yes.
There was a lot of young people asking for information about substance abuse. They said, we need to know when we are 10 and 11 years old, कि दुष्परिणाम क्या है? Because we don't know that. They have asked for de-addiction centers in every district. And so all of this, and of course mental health. I think we often talk about mental health and move away because it's extremely difficult to really provide proper counseling. Mental health, it's not really on SRH issues, but coping with expectations of parents, coping with lack of resilience, coping with stress because of exams. And in the
Which
middle
was what was mentioned in the morning.
in the
as well.
morning, yes. And also how young people get affected. Because the poll was ongoing when the Pulwama happened, and a lot of young people actually wrote that they want peace and security.
Yeah.
So it's that understanding from them, but I just want to end by talking about that young people also asked for governance and accountability, and which we are still trying to look at the data, that what do young people mean when they say we want better governance, we want more accountability. So right now, I want to end this part by saying that we are taking the asks from young people to various influential people. On 5th of December, we presented to some forward-looking members of parliament. Today we had hoped the health minister would be here. So it's basically now our effort is to take the voices of the young people and help all of us respond better.
Dr. Mehra.
Okay. Basically when we started working in adolescent in mid-90s, actually we didn't know how to work with them, right? We learned by doing, and we failed a few times. And one learning that came at that time, which I think still holds very good and it's need to be emphasized, working with adolescents without working with parents is an extremely difficult task.
Yes.
So whenever you enter communities, this I tell to every student, don't enter adolescent straight. It's contextual. Yes, you can do something in US, you can do something in UK, that's a different story. In India, when you enter into adolescent's life, see that you enter to the parents, right? Many of the needs which are being talked to polls now, you actually learn exactly that when you do start implementing that. What we used to do, a PRA and a PLA exercise. Through at that time, ActionAid was very active. So it used to give you a lot of learning what was the adolescent prioritization. In PRA, you do those prioritization, and health used to come much lower. It was the schooling, it was the safe environment, it's the girls' mobility, it is about eve teasing. All those came as part of their priorities. And when you would say, do you think nutrition is important? Yes, no, that kind of a thing. Do you think sexual reproductive health? But if you were to work with them over a period of 3 to 4 months, then they will come out to you say, yes, sexual reproductive health needs are important. So expecting they will tell you about sexual reproductive health needs on day 1 or too early is a wrong way to go about it. I think Shireen's work and many other works have done immense work to tell us what were needs. In 2020, I would say, yes, we all know adolescents need to be engaged, but it's the meaningful engagement and not a tokenism that must happen. And meaningful engagement has been defined now. What do we mean by meaningful engagement? And which does not mean that you get a disempowered adolescent to bring to your session and then say we had 20 adolescents telling us. In fact, when we were doing the architectural design of RKSK, Dr. Manoj, it was actually thought that how do we get boys on the board, right? And this is where the peer education concept, although we were ridiculed globally for that, but the whole purpose was how do you reach boys? We don't have workforce. How do you get 2 boy peer educators to come on the board who could engage?
Yes.
Yes, you could have a problem, you could have a challenge, but yes, we have no alternative, we had to do that. Third thing that I want to bring on the table is issues in adolescence have been a kind of a dynamic process. We have learned brain development over a period of time. We didn't know as much about adolescent in 2008, 9, 10 Dr. Sangeeta Yadav is here, is to know that what we know now in 2017-18, in 2000, yes. In 2019-20, we know that adolescent and young brain is working very differently. And I think we need to adapt our programming, learning from what we have learned from science. I think we did a lot of wrong messaging in HIV, which we shouldn't have done because adolescent and young people would not have even captured that, what we were trying to convey to them. So I think these learnings need to be blended along with the learning of the programming. Lastly, which I think is the critical part, a lot of NGO models have been created over the years. Lots of NGOs models have been created. It's time for NGOs learning to be taken into system, right? System's responsibility to deliver is ultimate. It cannot shirk itself off the whatever dividend we are talking about. It can't be just the responsibility of NGOs can do it. Systems have to do it. Systems have to have the ownership, capacities, and skill. I think we continue to emphasize to World Bank and to Bill Melinda Gates Foundation, both of them, to tell to the system, tell to the policymakers that there's enough of investment case in the literature now. If you want to share with you all on the economic front, I'll give you. If you want it on the rights front, I'll give it to you. If you want it on the gender front, we'll give it to you. But important thing is if you people move this, country accepts, country takes it. So I think the onus lies as much on, and even the UN systems, if I saw Purva here, so even the UN systems have to put together that kind of an evidence and emphasize on the government that they have to move through an implementation science and implementation research mode where the programming is more, we know a lot now, and hence we need to move that mile further.
Yeah, absolutely. I know, Medha, you want to say so. Please
Just
do
want
add.
to make one
yes,
point.
Yes, please do
that
add.
I think the point that Dr. Mehra has made is very, very relevant, that we need to look at how scientific advancements can help us program better. And at the same time, we also need to look at social norms and how young people are perceived. And here I will go a little beyond our definition of adolescence, because in our country, let's face it, for parents, even at 60, you remain a child. The ability to allow young people, and the definition of young differs for the health system, for schools, for families, across. And we don't really believe in giving agency to people to take decisions about their lives. We don't think that you're empowered enough, you know enough to be able to take that decision, and somebody else will take that decision. And to an extent, what Anjali, you were saying when we were talking, look at this room, right? Look at all of us. We are the ones taking those decisions, talking about those issues. Aparajita and Dr. Mehra brought out issues of young people. But we still don't think they are really there to be on the table.
Yes.
And I'll just make one more point. I was looking at the MMR bulletin that came out recently. And I was looking at the age-wise classification of maternal mortality. And 72% is in the age group of 15 to 29. 15 to 19 is 4%. And I was remembering that when I was in the ministry in 2009, at that time, when we looked at the MMR bulletin, the 15 to 19 category, it was 9%. And we started, and that time there was no adolescent health division. There wasn't the RKSK. There was just me in the ministry with attached to one officer, to try and make sense of it. And had it not been for people like Dr. Mehra to constantly push the agenda, it would have been very difficult. And when we looked at that data point and said, oh, look, suddenly there was frenzy that, oh, we need to focus on maternal health program on young people. So we look through the program lens and we try and classify, and what we do is we'll have these thin slices across programs, and those thin slices don't add up to a whole to respond to young people's needs.
Yeah.
We need to do a lot more. We need scientific evidence. We need voices from the ground. We need this kind of data. We need this kind of programming. We need the kind of analysis that World Bank does to really take the agenda forward.
And I think that's a great segue into my next question. I mean, one of the big challenges, and I'm going to start with you and have you respond to that first again, is the data and evidence. We do have good data. I mean, there is data that's available internationally. All of you sitting here accept that. There is good on-ground evidence that we generate on a regular basis. How systematic are we in feeding that into policy and program, and what needs to be done better? Because let's just look at the wide range, and today, and Aparajita, this will resonate with you and with Dr. Mehra. We're looking at the whole lot of LGBTQ community. We're looking at, you know, people with disabilities. These are young people with disabilities. How do we include them in our programming? So the role of data and evidence becomes very important. And you've done some amazing work feeding that back into policy and program. So, and Dr. Mehra has, of course, been pro at that. You're right, nothing would have moved if it hadn't been for him. So can you please respond to this, feeding it back into policy and program?
Yeah. I think, of course, we have a lot of very useful global evidence which will tell us what approaches work, what doesn't. But like you would have heard a million times, people talking about India not being just can't be treated like a country. You can't have a cookie-cutter approach. It's it's like multiple kind of cultures, geographies, and which is very, very true. But I think we do have structures which we can leverage, at least try and leverage. Every time there's no meeting on adolescent boys and girls or any issues when people don't throw out the numbers, we do too. The good way to get people's attention is you talk about I start most of my pitches by saying that, you know, the population of young people in India is more than the population of 18 Middle Eastern countries, because I'm desperate to get people's attention, right? But beyond that, I think what I see as a solution that we must all focus on is, like Dr. Mehra was talking about, how do we really work at scale? And when you work at scale, you have to work with the government. Not instead of the government, but with the government, right? And I think policy-wise, again, everybody would repeat many times, we have wonderful policies, and more often than not, backed up by budgets too. But there has to be enough evidence of how do you support the system to deliver. So let's say you have schools. Schools have teachers. Now, just because you've kind of, you know, curated a beautiful curriculum and given them a manual, we can't expect them to start working and delivering the next day. So our effort has also been to figure out how do you work through schools, how do you work through frontline health workers, Ashas, ANMs, how do you deliver a program for boys and girls, let's say through the Anganwadi system. And I think we're lucky to be in an age where there are policies which are really, really supportive. So when you talk of working through schools, we had the school health programs, adolescent health program, but now you have the school health program, which is mandating that 2 teachers in every school be trained to deliver this content, right? And also to kind of include the other kind of comprehensive elements. So we have been working with Jharkhand, and I'm very happy to see people from the, you know, important people from the Jharkhand government who looks after the adolescent health portfolio. It's been 12 years since we have been working both with the education department and with the health department in really trying to figure out what is that evidence, the data that we need to ensure, convince schools and other government platforms to deliver. And we have that. It's been documented, it's been published now, but what we're trying to do right now is use that data to replicate this program in other states. From Jharkhand, we've gone to Bihar, from Bihar, we've gone to Gujarat, and we are happy to go to other states too. But I think what is really important is, it's easy to say this works and that doesn't work, but you have to localize the solution, and that solution has to be informed by local evidence. We create a kind of curriculums, and we have done need assessment with kids in Arunachal, kids in Gujarat, kids in Bihar, Jharkhand, and across. All of them they are in a different setting. In Jharkhand, for example, the girls told us you have to include content on Dayan Pratha. You have to add content on trafficking because that is what the girls are facing. Whereas in Delhi, kids told us, "Arey, you don't have a chapter on cyberbullying." You know, which is also needed.
Which is needed.
So it's basically evidence which is locally relevant, locally created, and somehow used to support implementation at scale.
Yeah. Dr. Mehra.
You know, if to your question, is about data and measurement, right?
Data and evidence feeding back into
Into the program. You know, what gets measured is what gets done. Right? Let's follow that principle,
yes.
right? And as of today, measurement in RKSK is extremely poor. Can I say that, Manoj? Right? Because being the state chief, I must ask him, right? But we know that for sure the data is extremely poor. One of the things we need to support state is to support them in gathering data. We all must know in this room, we don't have indicators for adolescent health.
Yeah.
I'm part of the international global expert group, which is firmed up almost now. We are 9 of us from the global community. We have firmed it up, and by July this year, countries will be provided with specific indicators. And they'll be cutting across the thematic areas, including sexual protection. And those indicators should be there in the country. Till we don't get that, I think getting the process indicators, input-outputs indicator, is going to be the critical part of it. That if we can get, say for example, in a particular district, you have HR of this nature. Is this HR in place? Is this one indicator I want to measure? Second indicator I want to measure in the RKSK is their capacities. How frequent has their capacities been invested in, and how do we see that? Because these are two big indicators at the systems level, which is likely to achieve results. So if you were to follow 2 or 3 programmatic processes as input-output in it, health outcome indicators you could wait for, right? You don't have to rush into it. Get into input-output indicators as of today as part of RKSK programming. Once that happens, has anemia reduced or not reduced by this intervention? You'll be able either to give, say that to your National Family Health Survey, because that's doing it. Has unwanted pregnancy gone down? You can pick it up. I think school health program that we are talking about now, historically we reviewed, which started as early as 1971, school health programs. They have come in different names, different forms, different categories. कभी एक brand name दे देते हैं, कभी दूसरा brand name दे देते हैं, कभी 2 school ambassador बोल देते हैं. We keep on saying it, and Vandana is sitting here, please don't mind, right? So the point is she's managing the school health program now, right? That's why I'm saying, right? So the point is that you can go on doing this, but till school health programs don't have very clear-cut defined outcomes. What are you actually trying to achieve through school health program? Is it a political program? Is it a health program? Is it a health program with a very clear defined outcomes? Is it a platform to do deworming? Is it a platform to do sanitary napkins? Is it a platform to identify congenital or other health malformations? We need to be very, don't scope it to a level that in the end of the day you hit failure. So I have a feeling that also needs to begin with very clearly defined indicators. If these indicators are very clear, school health programs say, this is what we want to achieve, we'll be actually achieving only 4 indicators in 2 years or 3 years, expand to 8 indicators over a period of time, and get it. These days I talk only about systems. I don't talk about NGO programs anymore. I'm sorry, right? I seem that it seems to be now is the time when government should invest. With so much of money being collected from all of us through different taxes, through the different GSTs, we need to keep government accountable. And they need to we need to tell them that we will measure. We will measure what you do. Not just we, I don't mean me, means we all need to measure what we do.
Hold them
because I
accountable.
learned long way from BMGFs and others, it's a taxpayer's money. Or every time the donor would tell you it's a taxpayer's money, it's $1 to be accounted for. Why don't we ask our own government? It's INR.
Yeah.
I need to measure that INR. It has come from all of us. So hence it's accountable. That's why I feel your measurement, data, and evidence is fundamental to what we want to do in adolescent.
Thank you so much, yes.
It's not.
Yeah. I know, Rifat, a quick point, and then I'm going to ask a last very quick question and then open it up, because I really don't want to stand between you guys and the audience.
So I fully agree with everything you've said. And the only thing I would add on from experiences in other countries and other regions, especially on adolescents, it's better to measure 2 to 3 to 4 indicators, measure it well, really see in terms of diagnostics and what's actually happening during implementation, what's working, what's not, and use these a smaller number of indicators that are really compelling and really relevant, rather than having a long laundry list of 20, 30 indicators, and yeah, you're getting it, but then you have so many, you don't know what to do with it, you're not actually measuring it, and more importantly, rather than just monitoring, actually digging deeper to figure out why are we getting this number. So in terms of during implementation, if we have some of these process indicators, but just a few, then we have a better chance of actually being able to unpack and figure out what isn't working so we can fix it. But I think often, not only with adolescents, but with anything, often we end up getting into this, oh, we need all of these indicators, and it shows, oh, we're measuring all of this stuff, but then we're not actually doing anything with it. So it's better, I think, to stick with a few very compelling, powerful indicators and really follow those through.
Yeah, thank you so much. I think, it's the point, Dr. Mehra, that you brought up, and it comes through when we talk about, the adolescent area and the different aspects that focus on it, whether you're talking about a school health program or whether you're talking about education. And I think in the morning, Henk mentioned the whole thing about sports as well. So clearly, when you want to completely address adolescent needs and you want to look at a holistic development, there are different departments that need to work on. And that's one part of coordination that you look at. The second part of coordination is also amongst the donors. There are different donors doing different things, and and a lot of your programs impact the adolescent age. So how do you coordinate amongst yourself to make sure that there is complementarity? So maybe if I can look at the systems coordination, Dr. Mehra, to take your favorite word today, perhaps you and Aparajita could tell us a little bit on how systems could, different departments could coordinate better at the national, state, and district level, and then I can go to the donor coordination and then open it up. So very, very quickly.
I really wish to say that adolescent doesn't belong to health sector only. So it seems that we always need to think adolescent health. When you look at 5, 6 line ministries, each one of them deal with adolescent in one way or the other. So I'll give you one example of child marriage intersectoral convergence, which we did in Bihar and Rajasthan. The critical area was if education sector could pick up 2 indicators, how many girls retained in school, how many girls enrolled in school, and please give us age-wise data every year. Simple, nothing else. If the social welfare department could record number of child marriages happened in the district, and they have these data, please don't think they don't have it. But nobody sits together and takes the child marriage data, or in a health facility, how many adolescents came for that. So if you were to build two indicators, as you very rightly said, just 2 indicators, if you were to pick up 2 indicators in education, 2 indicators in social welfare, 2 indicators at the level, and you have a DPM in RKSK, who is the district program manager in RKSK. Fundamentally, what we are saying is that if 6 sectors were to contribute, we know the role of education in marriage, we know the role of education in contraceptive use, we know the role of education in gender equality also. So that's one indicator you want to pick up very strongly. Lancet Commission on Adolescent Health said 3 things. That these are the 3 mega things which every country must do. One is child marriage. Second is school retention, although people link it, but they made it separately. And third was the fundamental sexual reproductive health knowledge, attitude, and behavior, where they included gender as a central part of it, right? So somewhere we need to understand that if 5, like after 15 years, you can be employed under labor law, but in only certain kinds of jobs, right? You could have a data of linking them to skills. You could have a data on linking. All of them, when put together, makes the empowered or the most competent adolescent from the economic point of view.
Yes.
So hence, if even in RKSK, one of the deliverable, Manoji, is intersectoral convergence. Is that right? Right? They have to deliver on it. It's the most difficult thing to deliver. But I think in 5 districts we are working, we know intersectoral it has to be under a DM, and they must do that. If that happens, and if it is convened, don't worry about the central governments, don't worry about the state. Do it on district, you'll get it. I'm absolutely sure you will get it.
Aparajita?
Again, no meeting ends without somebody pointing out that we need to have a convergent model. So convergence in India is almost like that mythical animal, unicorn, Airavat, the flying elephant that we have heard about but never seen. But I agree with Dr. Mehra that it can happen, and that it is happening at district level wherever people are putting in the effort. I think beyond common indicators, people can also look at kind of measuring outcomes. So if you take adolescent boys and girls as a cohort, education can measure education outcomes, WCD can look at nutritional outcomes, health can look at health outcomes. There is skilling, there is gender-based violence, there is women's workplace participation, sanitation. We kind of map the indicators across departments, and there are at least 70 indicators from crime against women, from the Department of Crimes to IG weaker section that you can actually track. So I think what we really need to have is a common kind of an implementation framework, common measuring framework, common kind of accountability framework. If, just imagine if all these various youth programs from MOYAS, from skilling, from education, if all of it was to sit in one roadmap with all the budgets together and everybody in this 18, 19 line departments were held accountable to deliver for adolescent boys and girls, I'm sure we would have seen success. So I think, but convergent, because people talk about it and it's so difficult, I feel it really needs some very high level push, high level accountability for a convergent model to work.
Medha, I know the foundation has been really good in bringing partners together, and it happens in almost all your projects. As far as adolescent impact on adolescent development is concerned through various programs, how does the foundation really bring partners together to ensure that there is some complementarity, whether it's family planning or whether it's nutrition or financial services for poor or any other program that you think is relevant?
Yeah, but before I go into that, I just wanted to build a little more on Aparajita's point that very often at, when we talk at these kind of events, we talk a lot about convergence. But at the service delivery point, it's actually that one place where services are being offered, and that's where convergence does occur. It's really when we're doing this intellectualization of a lot of things that it seems that it doesn't exist. So we have excellent policies. We have people out there who are doing the work. It's somewhere in between that the story needs to be tied together, and we need to get our acts together on responding to that. But now coming to the questions that you've asked of me, how the foundation does this is at two levels. One is within the foundation, because it is a massive foundation, and very often we ourselves don't know how many departments we have within the organization. We struggle each day to figure out, because there'll be new teams that will be set up, and we're constantly struggling to understand. But there are mechanisms wherein we look at how we're building off each other's learnings and moving things along. Including things like looking at convergence in women's economic workforce. Agriculture is a big area that we work in, and within that, focusing on women farmers, smallholding farmers, and how do you empower women in that, and the impact that it has on their households. Looking at how we can layer messaging around family planning, maternal and child health, for that. Similarly, we have, when we're looking at nutrition, how do we try and bring those linkages with immunization and family planning? This is internal, and we try to do that. I won't say we're always successful. We're constantly on a discovery mode, so which is a good thing. At least the intent exists. What we also try to do is, and this comes from our co-chairs, there is a huge effort to try and always mobilize more money, right? So how do we create opportunities for different donors, governments to come forward and raise money across different areas? And this is not just for adolescent, much more in family planning, in new technology development. But that is something that we take very, very seriously. And that is a huge priority for us at the global level. At the country level, it is more trying to engage with other donors to see how we're complementing each other's work. So there is a conscious effort. I will not say that we're 100% successful in that, either externally or internally, but we're learning. and where we're always happy to be informed about what we need to do better.
I know that on nutrition, the World Bank and the foundation have come together for the multi-donor trust fund. So,
Anjali, before I specifically answer your question, let me just say, I just wanted to make 3 points, which the third, but very quickly.
She wants to, and I want to open it up, and we're
Great.
almost at the end.
So I think we would all agree that from a policy perspective, things are pretty good, right? Whether we're talking about RKSK, whether we talk about even SABLA, it's the program designs and some of these policies are also in line with what the global evidence shows us. So I don't think that's the issue. The key issue then comes down to implementation. When it comes to implementation of the programs, they're sparse, the coverage is sparse, implementation is limited, and there's no actual systematic streamlining of all of this, so it doesn't actually end up even becoming sustainable. Which then brings me to my just 3 real quick points. What do we actually do to move this forward in terms of convergence even? The first thing is, what do we do? And it needs to be transformational, because I think there have been many different things that have been proposed that are under implementation, but what's going to make it transformational, I think, is this this multi-sectoral approach. And I think I'd like to propose 3 things. 1 is enhance, 2 is empower, and 3 is employ. The first, on the enhance, it's the supply side. So enhance health, nutrition, and education services. And that's where the 3 different elements really come in, and the 3 different ministries also really come in. Empower adolescent girls and their families, which includes not only adolescent boys, but also fathers, mothers, mother-in-laws, grandparents, and religious and community leaders. And this is really the demand side. And I think much of the programming, I think that's where we have an even bigger opportunity to really push on addressing some of the demand side barriers, which are embedded in gender and social norms. And the third is employ. And this is where it's, even if we talk about adolescent health outcomes, the determinants are cross-sectoral, and hence the solutions also need to be cross-sectoral. So if that's what we need to do, how? I think there are 2 main things. One is, like I said, if the problems are cross-sectoral, we need to actually then work cross-sectorally for the solutions. Medha, you were talking about at the community, at the facility level. I would say we can take it even a step lower, because I think at community level, in many countries, it's much easier to work cross-sectorally, because the adolescent girl or her family, they don't see who's giving you the information or the service. They know that they need a comprehensive package. So how do we deliver that comprehensive package at community level, at facility level, at school level, and then up the chain? And often working bottom up might also give us success instead of only trying to work top down. The final thing, which is in response to your question, how do we actually, who does it, right? And this is where, if it's going to be a systematized, sustainable model, clearly government needs to take the leadership on it, but both at the national level as well as at the state level, because implementation is really at the state level. In terms of partners, I think it has to be government, it has to be global partners like the World Bank, like Gates Foundation, like many others, and local partners. I think for the World Bank, we also have internal dynamics that we need to manage, but I think we actually have a platform where on the adolescent agenda right now, we have a lot of support, which hasn't necessarily been so explicitly there. We have a country director who's incredibly supportive. We have a regional director for all of South Asia who's very supportive. And all of this support is coming from the fact that there's a recognition that adolescent girls and adolescents, more broadly, even with boys, that's the pathway to economic growth. So I think we actually have an opportunity, and we are really happy to partner and try to bring people together, because we have cross-sectoral units within our own organization, so that allows us to work across health, MWCD, and HRD.
Yeah. Okay. Thank you so much. I'm so sorry, but I think, you need to give a very, like a 30-second example, and then I need to open it up for questions.
Just an example of
we only have 5 minutes
convergence
for questions.
at community level. We are working with the government in delivering RKSK in 5 districts, 2 in Chhattisgarh. Yesterday we were in Bilha, which is the largest block in the country. People didn't tell us, nor our people, government, no one, but when we're talking to adolescent boys, they told us that, I said, how does it feel to be peer educators and part of this group? They said, we are doing great things. So I said, give me one example. They said, we have I think some ODF initiatives were going on, and the peer educators declared themselves as Swachhta Commandos. And they said, we have made the Bilha blog open defecation free. So I said, what did you do? They smiled and said, हम लोग 4 बजे हुटर लेके निकल जाते थे. I mean, I'm sure they did more than that, but this is an example of young people who are RKS ke peer educators actually working on sanitation indicators. So just an example of how convergence is
Fabulous.
happening.
That's really good. So I'm opening it up to questions. So we have 1, 2, 3. And yeah, so what I will do is take the questions. If you have it for someone specific on the panel, just please say it's addressed to that person. Or if it's a general where you want the panel to respond, we'll do that. So very quick questions, and then we'll get the response. So 1, 2, and 3.
Thank you, madam.
Introduction, please.
I am very...
Could you introduce yourself?
Oh, yes. I am P.K. Sharma. I am from Bureau of Indian Standards. So I agree with Dr. Mehra's, whatever he had said, system approach. So, but it has, since inception, India is having the system approach, and after 90s, it was more increased. Now, system approach is not the only solution. It is a strategic planning and the legal compliance also added to it. Then the system approach is effective. And the monitoring is required, but monitoring and measurement is also required. Then it is effective. Now, all of you might have...
So, sir, your question, please.
Question is, to all panelists, there is a draft education policy with Government of India. Is any program from your side had been proposed to the Government of India through our, say, health minister, like that? And what Madam Anjali Nayyar has addressed of LGBT community, which is now recognized at the university level, has anything improved, anything scheme is there in your thing? So that right from the adolescent stage, like our previous gurus like Vishwamitra or like that, so some person has to be trained during those ages, so that there is a shyness. The persons will tell only to that guru, teacher, not to the parents. Any problem or deficiencies between age 5 to 15 years. Parents, they are become very shy, and particularly mothers. So this is the...
Thank you, sir. That's
Thank
a
you, madam.
really very good question. So I'm going to let Dr. Mehra, you and Aparajita respond to that. No, once I take the questions, yeah.
Dr. Tej Ahluwalia, former scientist G and senior editor, Indian Council of Medical Research. 2 small questions.
Yes, sir.
Since I was the founder chief of health system research in India, ICMR, so I'll talk about systems. When any international organization or Ministry of Health or any government in India will ever give a weightage to the different life cycle of health, starting from pregnancy, antenatal care, delivery, childhood, adulthood, family rearing, caring, married life, and ultimately the old age home. We have so far not prioritized all these different components of life cycle, and accordingly allocation of funds can be given, and there can be mid-course correction, can review an evaluation of different components of health life cycle over a period of time, and funding should be given accordingly. One. Yeah. Secondly,
sir, what's the
when
question?
When will we start? How the change management communication can be done in terms of the family, because family is the first unit of education, adult education in any country. Father never talk about sexuality and adolescent to his son. Mother never talks to his son. Only the mother sometimes or many times talks to the daughter, not to the son. This is how the problem of the society is, that there is a communication between parents and the children, especially with the boys in the family. So when it will start? Thank you.
So is that question addressed to anyone, or you just want anyone from the panel to respond to it?
Anyone is welcome.
Anyone. Yes, ma'am.
I am Dr. Sangeeta Yadav, Director Professor Maulana Azad, Department of Pediatrics, and I have been quite in forefront related to adolescent health. And I actually have gathered the experience not not only as a clinician, but also as Indian Academy of Pediatrics and Adolescent Health and in different forums. So I fully agree with the fact that there is need for convergence and implementation. And I would want to know from the August panelist, how does Shastri Bhavan and Nirman Bhavan across Rajpath meet and get it implemented? That's the situation. Because I also do a licensing for Indian Academy of Pediatrics. So I have had all these multiple experiences as an expert or otherwise. So I just wanted to know, how should we go about the school health program, the Department of Education, HRD, and Ministry of Health, so that we all sit together and get something instead of just churning out figures, but implementing things and getting some outcomes. That's what is close to my heart. So I wanted that. Thank you.
But since it's broadly to the panel, and maybe we can all just divide up the questions and response. So, Dr. Mehra, you and Aparajita, would you like to take Sir's questions, please? Yes, to begin with.
Lately, the convergence has improved. That's one question which is coming between Dr. Sangeeta Yadav and yourself. You know, I've been one of the most critiques of convergence, and I've always felt it can never happen because it's not there in our DNA, right? It's just not there in our DNA to converge, right? But I think over a period of time, DNA mutations have happened, right? And it seems that we are more and more getting ready to convergence because all of us, in the end, feel that it has to happen. It means this time the school health program that has been created, the education department Shastri Bhavan mein nahi hai, nahi? Shastri Bhavan mein hai. So Shastri Bhavan and Nirman Bhavan have actually met, and the secretary level, joint secretary levels, all have sat together and prepared this program, school health program together. That's one. The education policy issue has become a bit political issue. You know this, right? I'm not going to dabble on that too much. But I think education policy issue is something which we know, having worked in education policy in early 2000s, and now seeing what education policy is changing, it changes with dynamics. But fundamentals don't change, please. Fundamentals stick there. You can bring one issue or the other or the third, depending on which background you come from. But basically, education policy is usually a very serious document, which we all, as an adolescent passionate person, should see very carefully that it needs to be done in terms of content. Sexuality education, from the point that Sir was saying, the parents can't talk with, we are struggling. I'll leave it Aparajita to answer that question, what is happening to sexuality education. But at the level of sexuality, family intervention, school interventions, vis-a-vis service provider in intervention, we know a lot about it now. There's a lot of evidence we know about it. And hence some of the programs which Aparajita will come, I got a backlash on that. I had a big backlash on sexuality education, suffered a lot because of it. So hence stopped talking a bit. So I'll just leave it to Aparajita, right?
You want me to face the backlash?
Yeah.
I'm actually going to take the doctor's question here. So Dr. Mehra talked about very high-level convergence at the Nirman Bhavan, Shastri Bhavan. I'll give an example of very real ground-level convergence in West Singhbhum in Jharkhand. So a few years back, WCT was running Sabla. RKSK was launched by the health. There was actually a tripartite MOU at the West Singhbhum level with the state government where we supported both the departments to deliver this program. I mean, and little examples of convergence. The program was run out of a room in the district hospital. And like Sabla said, you have to have Kishori Divas. RKSK says you have to have adolescent health days. Now, when you combine the forces of two and you have one day, obviously it's better. So I just want to talk about that convergence is possible. It's just that we have to put ourselves to it. You want to?
Maybe Medha can talk about conversation within the families, particularly given your experience from family planning, and you know that these conversations are very, very challenging. Do you want to take a stab
I'm
on
not
that?
going to answer that question. I want to give another example of convergence from the time that I was in the ministry and I was working on the menstrual hygiene scheme. And at that time, there was this effort to try and get SHG-based products into the system and looking at how that would happen. And what the Ministry of Health at that time done was to try and set up a committee headed by by then Secretary Sujata Rao, bringing in WCD, bringing in education, bringing in social justice, bringing in water and sanitation, looking at different components and building not just a monthly convening at the national level, but going down to the block level where officials were appointed to do that, so that there is a process of incinerators, the disposal was looked at. So in principle, all of that was done. And we learned those examples because we went on extensive field visits across states to learn from how it was done. And I think the next panel would be the best place to answer that. I've been watching you smile all through these questions, and I think you all will be the best place to answer this, because sometimes when we look at it externally, when I remember the times when I was in the ministry and looking at doing these things, we had a lot of successes, at least in planning it. I think the next panel will give us examples of what are the challenges of doing that and where are the bottlenecks that you face and what is the support that is required from other partners to really help bridge those gaps.
Yeah. Rifat, final comments by you and we'll close it.
I'm going to actually respond to that question as well. And as you were asking the question, I was thinking, I don't think we're really the right people to answer it. So I'm looking forward to the next session. But what I can share is what the bank's experience has been in a couple of other countries when we've tried to address things that are very multi-sectoral. Adolescence is one of them, but there are other examples as well. And I think it's a little bit, the phrase, think globally, act locally. We often use that to talk about sort of global evidence-based, but then we need to act locally that's tailored to the local context. But I wonder if this might be something that might be relevant here as well, where if we can think globally, quote unquote globally, and we think across these three ministries, if we can have some joint results that we can agree on, and this goes back to the measurement and indicators, if we can come up with 3 or 4 adolescent indicators, right? And I think Dr. Mehra can guide us on what those should be, but sort of impact level as well as intermediate level indicators that will require actions on all 3 parts, on all 3 ministries, let's say. If we can agree and commit to these results that we collectively will achieve, but then the actions will need to take place in many cases sectorally, and in some areas cross-sectorally, right? But if we can be driven by the results that we're trying to achieve, and that's what we're holding ourselves accountable for, some of those, the high-level results will be cross-sectoral. Some of the intermediate results will be more sectoral, and some of them will still be cross-sectoral. So I think at least this has worked in other places. I don't know if this will work in India, and I think maybe the next panel can tell us whether this has a chance or not.
Thank you. As you know, we've had an amazing panel, and they've had so much to share. It's been very difficult to try and keep them within an hour and 15 minutes, because so often I was tempted to say, can you please say some more? And I'm sorry, but time was a constraint. Next time, maybe Oman can give a panel like this double the time. But thank you so much. It's been a great learning, and I'm sure you've also